This. Okay, we're recording now. Um, okay, so we're going to cover like a rough framework that I use when I was training interns in office. I'm not going to pretend to know everything with this, but I think I've improved what I can teach and at least the way to understand certain things over time. And so I'm going to be covering roughly I call it the 5 steps of patient care. It's going to go over basically how to formulate a nice treatment plan using some of the tools that you guys already know and maybe some that you need to know, when to plug certain things in, and also too I'm hoping it addresses how to spend your continuing education dollar as well as some of your um, even some of the stuff that you pay for that is not going to be CE based, because as if you guys are students, at some point every year you're going to have to spend a little bit of money to go through CEs, and you might wonder, well, maybe I should do this course or that course or so on. There's so many ones to do, but based upon the framework that I'm going to provide today, you might be adequate with certain aspects of that part of the 5 steps. So why waste more money on it? We're going to cover the Q&As later. There's a Q&A section at the bottom where you can ask that question. They will be answered in order of received. I'll probably this time around, I'll answer them partway through as well as later on too. I'll probably only take a couple in the beginning here. So what I've noticed is when working with interns or people coming in to shadow is they don't tend to always know where to plug things in, and they know they've learned a lot of tools, they've learned a lot of methods and treatments and diagnosis and so on, and how do you use it all? Like, say you went to this FMS workshop and it's like, well, okay, how do I use this? And so plugging that into the system here is gonna help you guys a lot, and just generally figuring out where you need to be when you're with a patient. Now, I call this effective treatment mainly because it's not creating dependence. I don't believe in having people come in dependent upon you. In an ideal situation, I would like to have people in and out the door around 6 times or so, spread out through like about 3-4 months. What that might look like is I see them on day one, say on Monday. I see them on a Monday for an exam and a suggestion of what to do at home. The next week they come back, they prove they have some competency, they're feeling better, we're on the right track. And then I show them some corrective exercises and some loading strategies, and then they'll come back in 1 week or two. And then again, we change their program over time. So the goal is not only to get them out of pain, but also improve function. I like to use the strategy for most people, but it's very dependent upon how nurturing you have to be to the patient too. So it's a teamwork approach is what I'm getting at, is they're responsible for doing their homework. They're responsible for paying attention to what their body's feeling like, and using this cohesiveness of patient and provider. We're the guide and we show them what they should be doing. And most of the time, the patients can heal themselves. We need to be aware of the patient's unique goal. Your personal goals of what you want to do with your body is not necessarily what the patient wants to do. And so making sure that they meet their goals of running a marathon or watching TV, like it's dependent upon their goals. Like obviously we want people to be optimized, we kind of say, or performance, but it's really based upon what their goals are to consider if that's going to be effective treatment for them or not. Again, I don't like to nurture dependence. I'd like to make people independent. And I think this even goes to the route of that biopsychosocial, where you want people to not be afraid of moving and thinking that they're broken throughout life. So I like to empower them and let them know the body's resilient. And I think restoration of attainable lost functionality is an important part in effective treatment, because the person, let's just say we have someone with a knee injury, and so their knee hurts, and they say, "Oh, it just can't bend that way anymore, so I won't do it." And then you take that bend away, and they're like, "Oh, yeah, it feels better," and they just don't bend it again. Now that knee bend might be useful in certain movement strategies that that person needs to have over the course of life, such as a sissy squat or a small knee bend to get down to, like I did this before. I had a computer monitor in my hand, and I dropped my keys, and I looked down. I'm like, I can put the computer monitor down, or I can just slowly slide my hand down my thighs to pick up my keys and come back up. So that's a lot of knee bend in that movement versus a hip hinge or deadlift. So movement strategies, we want people to have a lot of movement strategies that don't hurt so they can do a lot of things, and ignoring the possibility that we can attain that function back in that knee might limit their movement strategies, although they might feel that it'll never come back. So that's a little bit of a tipping point of what their goal is versus what we think is best for them. But I think educating them in that respect of what is attainable, and if they want that again, is where this effective treatment kind of lies. Now, I'll give you guys some rough knowledge base, or a come from who I am, just so you guys know kind of a rough background. I won't spend a lot of time on this. Um, I was second in my class at LACC 2008. For PTs on here, this is a chiropractic school. So I like to say that salutatorian is smarter than the valedictorian, because you don't have to speak. And I hated public speaking. As you can see with podcasting, I'm much better now, but it sucked. I've taken the diplomate through the ACBSP. I've done literally tons of active release courses. I've done TPI's golf program medical for levels 1 through 3. Snell's Fix Your Own Back course. A lot of you at SCU have just come from that a couple months ago. Fantastic course. Shacklock's neurodynamics course, I've done level 1 and 2 for upper and lower. And so it's quite a bit. It's like 8 days worth of work. Koichi Soto was a good exposure into different planes of movement when rehabbing somebody. I've read McGill's books, which I will reference this stuff a little bit later too, in case you guys want to know what these are. I've read the books. I've never been in the workshops. I probably should go. I've read the Don Murphy Crisp books too. They're both excellent for cervical and lumbar. I've read the MDT or McKenzie books. Again, I've never been in these workshops. I probably should. Dan Johnism, I would consider as a lot of things that Dan John preaches. Dan John is a strength coach. If you listen to the podcast, you've heard me reference him many times. He encompasses a lot of level 4, which I'll show you in a second here. But I've been to his workshops. I've read much of his books, and I've watched his videos. His coaching style is really good. And I've been able to shadow a lot of good docs over the course of time and learn from them. So even some of my immediate competitors, I've shadowed them, and I've learned a lot, and we developed a good relationship and friendship. Lastly is I podcast Restoring Human Movement. If you don't listen to it, I'm through like 180 episodes throughout the course of the last 2 years. I've learned a lot because I get to interview people one-on-one. So listen to that, and so you'll get a lot of free stuff in there. Let's see here. So the suggested works, like I mentioned, I won't spend too much time on this. These are books or courses. So Don Murphy Crisp, low back, as well as Snell's Fix Your Own Back course, which I don't know how courses are going to go in the near future year, which is kind of why I'm presenting this idea today too. Shacklock's Neurodynamic book is a good place to start. Low Back Disorders by McGill, Don Murphy again, Crisp Neck. And also we do have some video courses that Cody DMAC put on. Those are on my website for low back, strength conditioning, as well as upper quarter. Fantastic stuff. Now, when we get into the model of what we're going to use today, this is what I show patients in regards to figuring out what we have to do. Like, where should we be going? And so step 1 is history taking, exam, and working diagnosis, as well as your differentials. But we cover that in day 1. Step 2 is figuring out a first aid or safety net. By the way, I'm going to cover all these in turn on their own individually throughout the remaining slides, just to give you a rough idea. And I'll keep coming back to this too. Step 3 is corrective exercises or corrective movement, buttressing, or building breaks. And this is kind of like your corrective exercise basket. Strength conditioning, that is your Dan Johnism or your Mike Boyleism. Just getting people to do really good resistance training based upon their goals. Then 5 is normal human movement or movement variability. I call it return to playfulness, because I know a lot of us, when we go to these workshops and seminars and symposiums, are like, oh, here's how we treat our athletes. It's like, I don't know about you guys, but I don't see athletes. I see athletic professionals. I see people who just have jobs and just want to feel good and look good and age well. So returning to playfulness is what I would consider is where I want to take people, or at least I want them to hang out rather than our athletes. And so step 4 and step 5 is where I believe most people should kind of hang out most of the time. They're usually not in pain during those parts, and they can get there very quickly. And that's usually just, it gives them general mobility and strength and movement variability throughout the rest of their life. Now, when we go into step 1 of the ladder of the pyramid, then we have, I could call it clustering data or chicken shit bingo. On the left, you see that this chicken happened to, I don't know what number that is, but he shit on the one next to 13. So that is a single shit. Okay. So that's where the single information lies. Now, if we were to put this chicken in like a 1 week's worth of wherever he wants to shit, it would be wherever most of the shit lies is where we want to use, where we want to have our working diagnosis, because there's lots of data points we're going to collect throughout observation of habits, history taking, orthopedic examination, neurodynamic testing, and differentiating tests of orthopedic results. I'm just going to hit all of these in a little bit, just to give you examples of how you can collect data through this. And honestly, when I go through a treatment with somebody, or even exercise with people, I learn more throughout those movements, because sometimes they'll walk in, they're like, well, my knee doesn't really bother me now. So I'm like, okay, let's do these tests. They're like, yeah, no, that really bothered it. And all of a sudden, when you tell them, hey, I want to go down and have you do breathing exercises, it's not the breathing exercise that hurts them, but coming back up from it. So you start learning the mechanics and collecting data of what bothers them with some of those movements, which aren't standardized tests. Now, observation of habits, you want to see, do they have a limp? How do they walk into the door? Are they standing throughout your waiting room and not sitting? And things like that. So there's certain things that you can pick up on if you're really keen to observing them as a subject versus just, letting them go through their paperwork. History taking, obviously, we all know that we collect a lot of information in there too. Orthopedic exam is nice, but I think differentiating them is actually better. I'll give you an example of a hip case that I had a couple months ago, where they had, I think I was doing Faber's test. No, I was doing Faber's test. And so I laid their leg upon their knee, or the shin upon their knee, and they're like, yeah, that's the hip pain right there. And they kind of pointed to the anterior lateral aspect of the hip. And so I was like, huh. And I noticed that their spine or pelvis was being rotated kind of a little bit with it. And so I reached over to the contralateral side and I pushed down on their pelvis, or ASI, slightly, to kind of give their spine some stability. And they said, oh, it went away. And their hip was through the same range of motion. And so with that, sure, we have a positive Faber's test, but actually when you differentiate it, then it's actually a positive spine rotational test, right? So I think observing of what's going on throughout each test and figuring out how to differentiate that, it's only going to come over time, but I can give you some clues to it too. Neurodynamic test it's helpful to figure out when something actually needs tissue work and when something is referred, or referred tightness or burning or stinging or stabbing or whatever. And ones that you're probably familiar with, but there's much more, there's slumps test, which if you move the foot and it makes the back feel better, then it's not a back spasm. And if you move the head and it makes your hamstring feel better, it's not a hamstring strain. But there's also ones of upper limb tension tests that you can do too. And so there's a bunch that you can do if you know what mechanics you're looking at. Now, I guess I should start with when we go into first aids, I'm going to first address that I'm not looking to, I won't be able to educate you guys 100% on each first aid and each strategy, because as you've gone through other workshops, those are, hours upon hours of learning just the nuances of one certain thing. And so with a lot of the first aids that I'll do, a lot of them are neurodynamic aspects, and a lot of them are, I've not gone a McKenzie course, but I read the book and I've used some of the McKenzie or Endridge learning methods. And so I'm not going to be able to really show you some of these, but think of it like we have a spoke system, or we have a wheel or a tire, and there's a bunch of spokes. If you're missing some of these critical spokes in here, remember earlier when I said I want you to consider where you're spending your money at? Fill in your spokes before you start throwing extra spokes into the same hole. And if you're missing some of these parts, just read a book. Like the book is a good starting point, and there's lots of great references around. But if you go to the workshops, I'm sure they're going to show you a little bit more too. Again, I've never been to some of the workshops, but I gather enough information from the books and shadowing people. So step 2 is, I like to consider it doctor established first aid, number 1, or patients showing what feels better. And so sometimes you'll have people come into your office and they say their hip hurts, and they're like walking around and stuff, and they're kind of like visibly in pain. You see their face, they're like, this doesn't feel good, right? And it's like, okay, so rather than like tinkering too much with them, say, look, get yourself comfortable. And they sit cross-legged. Huh, that's interesting. Like, does that feel better? Yeah, I feel perfect in this position. In this position, it feels like a 0. Okay, so that is a patient. The patient figured out their position of comfort. So if we think about what that is, and if we're talking about pain as a guide to us, or I like to call it an asset, using your pain system as an asset shows you the right position to be in. Sometimes with the patient, and so they can be very keen to that, and they get out of pain because pain helps them as an alarm system. And so there's nothing really wrong with that. And just let them have their first aid or safety net. And this actually cools things down, and it provides that safety net for things that you might do later. Say if we might have this hip case do something like lunges, and they're like, yeah, that hurts, doc, that hurts. And you're like, okay, so go into that position, makes you feel better again. Great. How's that feel? Oh, it's better. It's like a 0 out of 10 now. So that is okay, and it helps build trust. Now, there's many different methods you can use for your first aid. It could be doctor driven, or doctor you're performing it, or the patient can perform it. I prefer the ones where the patient is performing it. And usually we can find one with upper and lower extremity cases very easily. However, there's a little bit of an issue with it's acute, subacute, chronic dependent. If it's an acute case, say someone came in with a sunburn on their arm, there's not much you can do to cool that inflammatory response down. The body just says, okay, I'm gonna do this, right? And it's more of that level, like there's no position, there's nothing you can do to create spikes and valleys of their problem. In contrast, somebody with acute low back pain, they usually have, or let's say subacute low back pain, it hurts when they sit there too long, and then when you're questioning them, they stand up and walk around, and they're like, "Oh, yeah, this feels better." Like there's ebbs and flows with that. So if they're acute, this is a little bit harder, and I like to encourage people to let them know that there's a 5 to 10 day period of time where first aid just needs to happen. The body is doing its thing, and this is why I call this first aid. It's first aid because it's first aid. Allow the body to heal itself up. I had a cut on my finger one time. Here, I sliced it with some glass. It was pulsing for like 5 days. It just bone gnawing type of pain. Couldn't sleep and stuff. I took over the counter medication for it. It cooled itself down. It resolved itself. But I allowed the first aid to occur. And so if you allow the first aid to occur, it kind of sets a good precedence of how long should we be doing this? Because if you're using the system I'm talking about, you should have an expected timeline. And I think I should address that earlier. You should have an expected timeline of recovery if you choose the right thing. So if I choose the right first aid for somebody and they do the first aid or they dose it, then they should feel 50% better within 5 to 10 days, like a reduction of pain. Not restoration of function, but a reduction of pain. If I chose the wrong thing or they didn't do it and they like to just spread that scab or spread that cut on my finger, it's not going to repair itself as quickly. And so we call this the dosage effect. And so whatever the first aid is, whatever the position of comfort is, whatever the homework is that's deemed in the first aid category, do it. I like to explain it like to patients where I say, you ever go to the doctor and they say, hey, you have an infection. I'm going to give you this antibiotic and I'm going to give you one pill today. They reach in their cabinet and they grab a pill. And they say, I want you to go down to the pharmacy and grab another 6 days worth of these pills and take them. And you do, and you feel better. And so the same thing happens here. It's a dosage effect of the first aid or safety net. Note that this is not always required. Okay. It's nice to have for a lot of people because you establish a good trust and it's really easy buy-in. But it's not needed on everybody. I've had enough cases where it's like we start going down the route of this first aid, and clearly the person can, like, they're just generally just unstable. Like I don't want to say clinically unstable. Let's just say deconditioned. Like they're just generally not strong. Lack general physical preparedness. If I just got them to walk, they would probably feel better. So not everybody needs a focal, nuanced first aid, but it's nice to have. So into the next step, we have step 3, which is where a lot of students come in, they say, look, like we know our diagnosis, we know our exams. I'm not sure when to use them all. I don't have a good exam flow. And we know how to adjust, we know how to do tissue work, and we know how to do all these, modalities and whatnot, which is all in step 2. Step 3 is where they're like, well, I went to this class and we did some exercises. I don't know when to use them. Or there's the other situation where we just have a doc or a DC or PT who's only really good at step 2, which is reduction of symptoms and manual therapies and so on. But there's nothing wrong with that, but they don't have the experience or skill set with these. So they might miss this spoke. If you have this spoke, you just need to know when to plug it in. And so this is probably the most challenging thing for me to explain to people, and this whole slide is actually probably it was one of the main reasons why I even created that flow in the first place for interns that came in, is because I use a lot of step 3 in my practice, like a lot, like even in replace of step 2 oftentimes, and it makes people feel better. And so the interns or shadowers will say, well, why did you pick that? I say, I don't know. Like it seemed right. Like I like there's a theory I'm going off of, and I'm trying to chase a theory down. And the exercise doubles down on the idea of that theory of the working diagnosis. I'm basically trying to prove or disprove the working diagnosis. By the way, I should back up real quick. In first aid, we're looking for a 30% reduction of symptoms in that same session. If you get that or more, you picked the right first aid. If you didn't, keep looking, or maybe they don't need a first aid. Um, it's not uncommon to get 50% reduction or more, but it doesn't stick unless they do the dosage effect. Now, back to step 3 again, there are a lot of situations where you can get the same reduction of symptoms, like 30%, 50%, better range of motion, being able to touch your toes by doing a step 3 suggestion. And so the way I break these down is I call it correction of movement, buttressing, or creating a braking system. Now, I'll be honest with you. I don't know if this is the best way to put it, but it seems like it makes the best sense at this point. So I'm going to reserve the right to change my mind on this later. Um, Corrective is like our patterning. It's like when you're teaching someone to move at a ball and socket joint versus only at the spine. And that can happen for necks and backs. Or maybe someone has knee pain and you're teaching them to use a more hip dominant strategy for a period of time while you deload the area of concern, the patellar tendon or whatever it might be. The buttressing effect is more of a co-contraction, kind of based around the McGill model of the guy wire system of the low back. And so we can use a frontal plane challenge to decrease the amount of sloppiness and sensitivity of the back, or to support the back in that case. And you can use it for necks and all these other spots too. I think DNS does a good model of this. I think they call it joint centration, or this co-contraction around a joint to create stability there. So there's a lot of different ways to do this. Again, I'm not hung up on the idea of just only using these methods, but there should be a purpose. I don't know if you guys are, I hope you guys are seeing that. There's a purpose. There's a reason for suggesting it. And I'll give you some examples too. A braking system is building tone change for anti-movement for the triggering movement. If someone were to have pain with bending forward with their low back, or flexion intolerant pain, then you might build the posterior chain a lot, so much to where they're really like this is what the body inherently does, in my opinion, is it makes the erector group, the spinal erector group, build a lot of tone so you don't bend forward. Sure, it feels like a muscle spasm, but you're trying to protect against the bigger evil. And so we can double down on that idea and build more of the anti flexion braking system. Now, to be clear, I think this is where our professions tend to fall apart when we get into the corrective exercise realm. And I'm no different from this. Is I feel like we do corrective exercises whenever somebody comes in because we feel like it's what they need, or it's like what we know. And I don't tend to suggest corrective exercise all the time. Again, at the bottom, I said not always required. It's required when you're trying to build a pattern or create a momentary protective mechanism against the offending movement. And so we don't always need to have people do this. And actually, step 3 is just a stepping stone into getting them into a loaded ADL movement, such as picking up a box or reaching across their body to pick something up out of the back seat and not hurt themselves while doing it. Granted, there's things that we can do, like say in that instance, the shoulder, because that's a common thing with a impingement. They say they're reaching in the back seat and their shoulder hurts because they reach too far and they grabbed a purse, which has a long moment arm. Now, we might want to build some co-contraction around that shoulder to build some support for that movement, but we don't want to keep them in this babied version of loading forever. I mean, I think it's actually irresponsible. And I think we should, as soon as possible, get them out of this portion. Now, I think we can have people do these exercises for literally 4 to 6 weeks and not change really too much at all. And they're still going to be okay. But you can start building step 4 in the process of this. or in combination with this very soon. I've had people go all the way through steps 1, 2, half of 3, part of 4, all in one day. And when they're very trainable, and other people, I only end on step 2. And that's it. And it's based upon how trainable they are and how willing they are to learn. And so I want to make sure that everybody understands I'm not against tissue work or adjusting or treating people like babies and crawling on the floor. And I use all this stuff, but there is a time and place. And so if a person comes in and they can clearly do things standing on the ground, foot on ground, clothes change, and I don't need to patchwork in any of these parts, then you're regressing them too far. So I'll give you an example of this one more time. So patterning. I think Mike's on this podcast or on this webinar. So there was an instance where a guy came in where he had back pain. He was a CrossFitter, is a CrossFitter, just general population CrossFitter, I'd call it. And so he looked like a disc to me. So I treated him like a disc. I did number 1. I went over into here. I went to step 2 and I did some end-range loading extension lumbar spine. That had no effect. It didn't have a 30% change. And so I went into this step, which was I first picked co-contraction. And so I went over the McGill style because I was still thinking disc. And so I went through bird dog, side planks, McGill modified curl up. And he's like, I feel like it didn't make him worse, but he's like, I don't know. And then so Mike steps in and he's like, hey, I saw this thing before. I want you to put this dowel on your back. And so he patterned him into a squatting pattern and just leaning forward from the hips versus using the spine. And the guy's like, whoa, that feels way better. And so Mike picked appropriately in this. I'm not saying I didn't pick appropriately. I just I would have had to keep moving, and he selected the right one right off the go because it made a definitive change that day. So based upon what you pick, you just have to, I believe people only need about 25 different corrective or correcting or braking system exercises that you cue different ways throughout different things. And when I show this pyramid, just notice that the bottom, all of these histories, exams, working diagnosis, there's a bunch of them, right? And every exam looks a little different. First aids actually become very much similar for a lot of people. You notice that for all these various different pathologies of the shoulder, they tend to just kind of do this broken wing presentation. So is a sling really that bad as a first aid in this, And then step 3 is kind of like things become really close together again. That's why I said 25 different exercises. And step 4, when we get into that, it's a lot of push, pull, carry, squat, and hinge. Like I'm still going to have someone with a shoulder condition squat. So does it really change? Like we're just kind of narrowing things down there. Now, when we're finishing off step 3 here, and I probably will take a couple questions here in a moment. Selection of step 3 exercises should have a purpose. All right, based upon the working diagnosis. All right, if you feel like someone has let's just say they have a low back disc, don't give them a sit-up. But if you think they have stenosis and or if a set syndrome, let's just say, give them a sit-up, because like it's one will flare up and the other one won't. And so there should be an immediate change, and the corrective exercise should not be painful. It should be effortful. And if you're not finding the improvement you're looking for immediately, then regress to step 2 and step 1, reevaluate your data. I'd spoken to someone about a year ago, and they said, I treated this person really well for a labral tear in the shoulder. It was a grade 1 type. It wasn't that big, right? And so they explained what they did. I'm like, that sounds really good. I think you missed something because this should work on a labral tear or on a grade 1 labral tear. And so I think you should go back to step 2 and step 1 because I think you missed something. I had someone recently that I worked with them about 4 times, and they responded really well to corrective exercise step 3 for the shoulder girdle in office, but it didn't stick. And so I did a video session like this with her, and we did a better step 2. And all of a sudden she could put her arm over her head, no symptoms whatsoever. I checked back in with her a week later. She's like, my shoulder doesn't hurt whatsoever. And so now she can go back into step 3, and those things are going to stick better. Like things like your 6 scapula type of workouts, like those would then work better if you address the long thoracic nerve first, right? So make sure you're going backwards if need to. Now I'm going to jump over here to a little bit of the questions real quickly, just to make sure that I'm not missing anything. Any questions anybody has, now's the time to ask. You have 10 seconds. On the bottom, it has Q&A, or else I'm going to go straight back over to the workshop again. 5, 4, 3, 2, 1. Okay, no questions. We're going to, oh, gone. How do you measure 30%? So 30% change, I'd say, is subjective. And so they say reaching their arm over their head is one, where like you let them pick a movement. Like we might pick some of the movements you find in the examination, such as like flexion, abduction, and so on. But I usually ask them, what is a meaningful movement to you? And they say, well, it really hurts when I put my arm behind my back to, put my belt around my body. And so, great, let's use that. By the way, I tell them, I say, don't pick a stretch. That's hard because it'll always get through more range and you can always provoke it more. So that 30%, after we do that intervention, we ask them, how does that feel? And do that movement again. They say, well, it feels better. And so I usually mention to them, we're not looking for a complete change because we're going to get that complete reduction after you do your dosage. We're looking to see that this is a favorable direction to take. And so they say, oh yeah, that's much better. And usually you can look at their face and they're like, oh yeah, that's way better. And so that's how I would probably measure that. Obviously they're not going to know 100% what 30% means, but I think you're going to know definitively the way they say it if you're on the right track or not. Hey, how's that feel? I think, yeah, like they're trying to please you. That's a no, and just keep looking. Okay, we're going to go back into it again. Thanks for being on Easter, everybody. That's everyone's probably got things to do. Okay. And by the way, I didn't plan this on Easter. It just happened to our scheduling software didn't have holidays on it. Weird. So we already promoted it, so everyone's here. So step 4 is I like to call Dan Johnism. On the podcast, I am interviewing Dan John. I've done it in the past. And I'm doing it again, or I've already done it, but it's going to release in about a month here. He's got some really great information and really simple ways of coaching and providing movements that are so we're going to strengthen movements, not muscles. And so it's not necessarily isolation. His whole thing is it just build a sustainable program that lasts throughout time to get the change that you want. It's not a rush. So kind of doing things in moderation and making sure that like the person understands that it's not a race. Like this is not going to be, step 4 is not the goal, your goals as a power lifter. It's the patient's goals just to feel better. And so make sure that you don't insert into their programming your goals, because that'll be a critical mistake. And don't keep always don't change the goal. Like if you say you want them to be able to deadlift body weight, a handful of times, just that's the goal, don't keep moving it. Like for me personally, after I had my second back injury, which wasn't really that bad, I started thinking about, what do I need as an individual as a goal for it was during deadlifting. So what is my need? And so I started thinking, I'm like, if I can do over 200 pounds, 225, something like that, like by myself, once or twice, that would be on any given day. That'd be pretty fair. I'm okay with that. Anything over that size, I feel like I need to be asking a friend to help me lift it. Like we're going to be lifting my hot rod body pretty soon. I could ask my dad to do it with me and him, but I think I just ask for people to help me. And so make sure that you ask them what their goals are, but also patch in maybe some suggestions. Like if they say, no, I don't want to be able to deadlift anything, say, well, you're going to pick up that bag of dog food. So I think 40 pounds is about fair, and you do it once, you turn it over, you dump the dog food out, and you do that once a month, right? Because you got to fill up that little container you feed the dog in. So these movements are intended to stimulate things you're going to do throughout life. A push, pull, carry, squat, and hinge are the major movements, but I suggest break them into bilateral and unilaterals. Usually I will program this in based upon, again, the working diagnosis first, and figure out what I need to bias the movement and the effort towards to get the results that I need. Like an example of this is if I had someone with groin pain from a true labral tear, I'm not going to be able to get them to squat really that deep. And I don't even know if I need to at this point. And I could suggest a push, like a bench press or a single arm push exercise, but they might think I'm crazy. Like they're coming in for a hip problem and I'm telling them to push, even though it builds that anterior sling, like it's still useful, but maybe I pick something like a hinge or a suitcase carry. Like you can pick something that's a little bit more focused on that region to build resiliency and strength throughout that region first, and then you can patch in the other things later. Usually, again, unilaterals, I'll say like, look, like it's nice to teach bilaterals, but people are like, so am I doing this right? You know, it's like, does it hurt? No. Okay, you're only lifting 10 pounds. You can do it wrong. That's okay. Wrong, quote unquote. And also you can, like half the time you see them when you're teaching them, they're lifting up that weight a couple times and you say, okay, go ahead and put it down, and they'll put it across their body into a weird spot and they don't hurt at all. And that's how they usually pick things up. Now, I think the conversation changes a little bit about perfect and not perfect form based upon load. Most people don't, they're not picking up like 100-pound weights across their body every day. And I don't think they should, but it doesn't, like you can teach them to navigate that 100-pound weight, and that load dictates the strategies available to you to move. And so we can build that up, but also the movements they're going to be exposed to throughout the day are things that are not as weighted, and they're going to cross their body. They're going to reach down with one hand. They're going to kneel down. They're going to do unilaterals all the time. And so we might as well build up a lot of those too. Now, the implement and the variation of, or the implement and the load they vary. You see Dan John here has a kettlebell, but what's wrong with using a bag or a dumbbell or a baby? Like there's nothing wrong with using something different, because sometimes people they're like, oh, I don't know. I don't have that object. Or they'll see the object. I had a lady like this. She's like, I'm scared of weights. And so I say, go grab you have a bag in your car? And so she had a bag in her car it was pretty heavy too. And she wasn't afraid of that. So the implement doesn't matter. And honestly, having different implements changes grip, which is a useful thing in life too. And it helps, in my opinion, lock in some of the shoulder as well as the core. So I think people should live in steps 4 and 5. And I think 2 days a week is a fair amount of resistance training, not killing yourself, but just generally building some strength and some mobility. Like, I think this is a good spot for most people to hang out and be, because if we go back and look at this thing here, if you look at steps 3 and 2 and 1, these are symptomatic cases. Like if they're doing this, they have symptoms. Let's get them out of symptoms, build the body up to a resilient structure that it is, and let them navigate life with some load safely, and get them to play to experience the movement variability. So I've had quite a few people that are like, I don't really like weight training. And I tell them that the weight training that we're doing here is just showing them how to move. It's like teaching them. It's like a dojo. It's like when you go in there, it's like you're not going to get attacked every day. You probably won't get attacked there ever, but you're just making it seamless. And so it's training you to move loads safely if you experience it. Oh, but also you get the bonus of mobility and strength. Now, with your step 4s, the movements, load, pace, and progression should be selected based upon your working diagnosis. All right. And so just like steps 3, step 3 can be extremely therapeutic. Corrective exercise can be extremely therapeutic, and so can 4. If you know what you're doing and what you're suggesting, make sure it's appropriate. So using the data collected in the examination and the patient's response to steps 2 and 3 will assist you in appropriately selecting exercises. As I gone through, like you'll see, I'll tell you about some of the workshops I'm putting on, the virtual workshops later. I've kind of laid out a rough parameters of what I would suggest first. And so again, the reason for this was, and this is what we did with the interns, is just for teaching purposes, is I made like just PDF files, like Word document files. They were so blank. All it said was steps 1, 2, 3, 4. And I said, for a true hip case, a groin pain, FAI hip case, what are your possible working diagnosis? What does the history look like? What is a good first aid? What is a good corrective exercise to have, number 1? And then what's the second or third? And then what is a good starting step 4? Are you going to do a push on this person? What would you pick and why would you pick it? And so I wanted them to look through these documents just to see the title first. And then we actually have a Google Drive file with this for incoming interns. So look at a Google Drive file. and they say, I want them to write it down without looking at what I said, because I want you to know I want you to know or think about what you're doing and create a purpose for it. There's no wrong answer, but just figure out a system that would theoretically work and then test it with patients. And if it doesn't work, you can revamp it. So this step 4 can be used as soon as day 1, and it can be used in place of steps 2 and 3. Returning to playfulness is movement variability, and I think this is the most important part, and it's really the hardest part for most people to figure out, because once they get out of pain and they do a little bit of weight training maybe, and they're like, you know what, yeah, I do my exercises twice a week, and but when do you think I can play tennis again? You can play now. Don't you think I'm too old for that? No. Well, how do you get them to start experiencing these movements that are not robotic? Because with weight training, especially with load, there's again the quote unquote perfect form, or there's less risky form. And I think what we need to do is expose people to lower loads with more movement variability. If you look at the gentleman on the right pushing this grandpa with the kid, is his upper back perfect? No. Is the older guy's lower back perfect if we're talking about weight training? No. Is it perfect posture? No. But does it hurt? Probably not. He looks like he's smiling. So when I think of how to explain this, I've explained it to patients this way. I go to the baseball, I play baseball, and I go to the batting cages. And so the iron mic, when it's throwing, I wish everything was down the middle, but it's not. And if it was down the middle every time and I could hit it and I had the perfect swing, it would go far. But it's up, it's down, it's in, it's out. And so based upon where I'm trying to hit it, and also where the pitch is and how fast it is, my body has to make some momentary changes, but it doesn't hurt. And the end result is still a base hit if I did it well. And so that movement variability, there's not a perfect swing. It's just the right swing for that situation. And there's lots of different planes of swings and speeds of swings and so on. And movements are the same way. With squatting, your feet don't have to be perfect. I would love them to be staggered a little bit, and I want you to have a weight in the side hand. I want you to be looking to the right when you do it too. Or you can just get them to have fun. When they have fun like this, like, you don't necessarily have to coach these things quite as much, but there's certainly ways where you could, go do a yoga flow and things like that, but they're still structured. And so I'd rather them go have fun. So that's kind of the major parts of the 5 steps. Here's what I'm offering you guys, and I'm going to take some questions too, is I know right now there's lots of webinars going on and there's lots of things to consider. And I know money's tight for a lot of people, but here's what I'm thinking is I've had a lot of people call and email students and doctors to say, can I shadow you? And over the course of the last couple of years, I've said yes to a lot of people. And I think my answer is going to be no now. And here's the reason why, is because people who have come to shadow never fully get a grasp of what to implement. And so they like the idea. They're like, oh, this sounds really, I like this flow. I like it. It sounds good, but how do I do it again? I even had a workshop last year where a buddy came and he only took one thing away from the entire 12-hour workshop. And he's talking to me about cases, and he's like, yeah, I'm having this problem with this case. And I'm like, dude, just do that one thing we did. And he's like, I don't know. Like, it's just, I don't know. I don't have enough time right now. And like, it's just, I got patients every 30 minutes. And so what I've concluded is if you only shadow, or if you only do something like that, or like a single workshop, you're not going to take any of this away. And my mission is to improve the profession. That's why I have this podcast going on for nearly 2.5 years is I like learning, but also too, I see that we can all improve dramatically. Even myself, I don't pretend to know everything again. And so what I'm proposing is, let me share what I know through virtual workshops, almost like a quote unquote internship. I'll do a step-by-step, regional and case dependent. It's 2 hours long. I'm going to cover these things: hip, shoulder, cervical, lumbar, and upper and lower radiculopathies. No CEUs are available. But basically, I want only a handful of people to be in this relationship with me, because again, like I would love to say that it's useful to me and the person to say, okay, so I saw that you do that one thing in the office. How do we use that again? it'd be easy just to say, look, I don't like, just remember the whole theory, the whole pyramid of what we did. Do one of those, like go back to step two. It'd be nice to have a common language here. So I want to, like, I feel like to make a change in the profession, PT and DC, I think there has to be structure, and that's why I'm suggesting these workshops. So it's Q&A time here. I'm going to pull off of this PowerPoint here for a second and see what kind of questions we have. I will go back to the PowerPoint again. So I have a question. By the way, now is your time to answer or ask any question. There's no question too bad or too good for this. And again, I will not, I mean this in the nicest way, I will not answer your question if you message me on email, on Instagram, because I'm asking you to do me a favor and ask it here, because I'm sure everybody else has the same, or someone else has the same question. You're going to save me a lot of work. So someone asked, after coming from first aid, do you feel like periodization is necessary in step 4? Maybe. I think it depends on what like how far you want to take the person. Like I've asked people, or I've told people before, like I had this old chart on the wall at the office that I took down. I feel like I'm always changing, what I'm suggesting people, or at least like the way I'm saying it. And so I tell them at some point in step 4, I'm not going to be very useful to you. And the way I would interpret this question is, if they need periodization, they should be at a strength coach. Like, I'm not suggesting we become strength coaches. I'm suggesting that we know the best information and data about their current condition to get them to the point where they can start doing things that is not like crawling on the ground and doing things like that. So I don't tend to go that far. I go more of like, I guess if you're asking like what I'll actually do in office, like I'll usually teach tension through the movements, and then I'll move weight up a little bit, and then I'll sometimes fluctuate it. So I'll do a little bit more of an undulating versus a linear progression, but I don't go as far as breaking them into, here's what we're going to do during this period and that period and that period and so on. Usually I'll just say like, look, like you just want to feel good, right? And I'm like, yeah, all right. So I want you to do this one exercise circuit 2 times this week and come back, or sorry, 2 times this week for like, say, if they're at a point where they're not symptomatic and they feel and they're in control, and they could, if they had symptoms, they could reduce them. There's no fires going on. I'll say, come back in a month and allow me to change this program for you. Because today we only had 30 minutes. We only went through a hinge and a squat and a carry, and that's it. And I need to build up the push and the pull, because the body is one unit, and these 5 movements go very nicely together to build a nice support system for everything. So is that okay? And they say, yeah. And they'll come back next month, and we'll then patch in those other 2. And I might change the weight on the ones we did, or I might change, I might change it into a unilateral or something. But I don't really go too much into periodization. I think just doing something that these people haven't been doing for a while and creating a chronic situation for the body to create the adaptation is what I'm able to do in the beginning. Good question. We have another question. Management strategies for a patient who is too eager to return to play. That is a good one. I had someone recently where they were very open about, they're like, I'm gonna lift, and I don't want to do any of these step 3s with you, really. And so I'm just letting you know ahead of time. Like, they're open about it. And so I said, okay, but I want you to know that here's the reasons why we're doing it. She came back the next time. She's like, yeah, I felt better for a couple of days, and then it got worse again. And I said, okay, so we're going to do these again. And so she just didn't like it, and so finally, like she spoke up before she left, and she's like, I'm really frustrated that I'm not getting better. And I said, look, I'm gonna be honest with you. You're not making this easy for yourself or for me. And so I want you to know that the more that you resist what I'm telling you to do, the harder it's going to be, and the longer this is going to take. And so the funny thing is with them is that the gyms recently closed, right? So the gyms closed, and she had mentioned to me after that, we did a video session, and she said, I'm very thankful this gym closed. I should have listened. I feel so much better now. And she's very open to doing push, pull, carry, squat, hinge based upon what she can do. And she's still challenging herself very hard. But she's like, I feel so much better. And so with that, you could tell you could tell a 15-year-old kid not to do something, but if they want to do it, they want to do it. And so I would just let them know that you're open to, like, you're open to communication about it, but you want to discourage them from doing certain things for certain reasons. And then if they choose to do it, they do it. It's about them choosing. They're part of this. They're this team. You're on a team. And so if you don't explain the reasons why, that's your fault. But if they choose to ignore your advice, that is their fault. Either way, though, they'll learn and you'll come to a nice understanding. Next question. Would you say there's a certain course slash book that are minimal, that is a minimum standard for a proper evaluation? I feel like school didn't give us all the tools that are needed for proper exam and eval. I think it depends on region. I think if we're talking low back, if you guys took Philip Snell's Fix Your Own Back course, I think that is very good. He's extremely thorough. By the way, if you didn't, I want to shame you right now, because that is the most affordable, most direct, most comprehensive course for the low back that you're going to find. He encompasses many different aspects, to neurodynamic concepts, to McGill's work, to MDT. He includes a lot of things and shows you how to use them together. So I don't know when all these courses are actually going to go live again because of the whole social distancing, but that is one for low back. I don't know one for neck, but CRISP covers very well different tests for different conditions, and I would suggest looking at that. He also, if you looked at that one for low back, that one's a good reference too. McGill's book for low back is really good because you can stress test things like disc and so on. Or, you know what? I'm doing workshops on this stuff. So these workshops are, you're going to see my exam flow for hip, shoulder, neck, low back, as well as radicular symptoms of the upper and lower. So this is why I'm doing this. Okay. And so you'll see it all on video, and we'll explain all the differentiators. And so I just let you know, I've made up some of my own differentiating tests you're not going to see elsewhere, but I'll give you a theory of why. And I hope that you guys can make up your own test. I do think the school gave you a lot of great tools, but I think what happens a little bit too is that I remember seeing this slide somebody put up about these 4 different types of hip impingement, different quadrants. I haven't had to send a hip out for a surgical consult or intervention in like 3 years. There was actually, sorry, I take it back. There was one recently where the MRI findings was a little bit iffy. There was a large tear to the obturator internis. It's weird, and the quadratus femoris. But other than that, I haven't sent anybody out, and they pretty much all get better. So I think the tests they give you are actually pretty good, and actually I think the diagnosis, the diagnostic ability, you guys have it, but the problem is I think you don't know when to just get enough information to do the work. And I think over the course of the last 5 years, I'm not going to say I diagnose less. I figure out what it's not. I figure out probably what it is. I don't figure out the quadrant or the nuances, but I see what reduces it, and I follow that path, right? It's like you can forever start like thinking about what stock to buy and looking at the P&E and the evaluation and forever, or you can just buy it based upon everything else looks fairly good, and then you see that it's working, something's working, and you follow that path. So I think take action a little bit more than just work on the nuances of diagnosis. But I think the thing that people are more worried about is, am I going to catch the red flags? And I think the school gave most of you adequate tools for that. By the way, there's only one more question you better start asking. I see a lot of people in there. Please ask the question that is top on your mind, even if it's related to one of the questions I already answered. Okay, last question. Do you feel like most patients are willing to continue care to steps 4 and 5, or do the majority discontinue care after symptoms resolve? So I found that most people are very open to going into step 4. Step 5, I've done probably not a good job of actually setting formal parameters about what to do, because it's kind of independent about what they want to do. Now, I'll go through a rough flow of what I see most of the time with people. First one, I go through a very thorough examination, and I give them 1 step 2 or 1 step 3 based upon what I'm seeing. And it's kind of like when I give if I give a little bit more, it's kind of for me, like I just want to confirm that I'm on the right path. So if they do that, they'll come back roughly in a week. They come back in a week, I'll say, great, keep doing that step 2 or get rid of that step 2. And we're going to do these step 3 and this 1 step 4. Okay. Next time, come in. So that might be a couple weeks later. Great. You've been doing your step 3s and that 1 step 4. How do you feel? I feel pretty good. Cool. So I want you to warm up right now with your step 3s, and I might add in 1 more step 3 or change 1 based upon what I see, because I might have to build. Maybe it was too robotic, and I need to get a little bit more flowy, or a little bit more rotational, or patch something else in. And then we're gonna continue on. Let me see how that 1 step 4 looked. Oh, that looks pretty good. Let me add another step 4 and another step 4. So that's 3 step 4s. And so this is on, let's see, exam and step 1. That's 1 session, then 2 sessions, and 3. I think that's 3 to 4 sessions there. And then we'll usually get them into the point where, again, they'll get to the point of its inception, usually, where they'll say, what else can I do at the gym? Or what else can I do for weight training? Because they're excited they can do something. And so usually that's like, I can go with you to the gym, but I'm not going to. Or just come back in a month or 2 months. I need to change things for you. I think if you framework this really well with people and let them know that you're not looking to drag them on forever. And if you mention, hey, I need to see you 6 times or 10 times or whatever you decide, I think a lot of times in the beginning, they'll say, oh, that's every 2 times a week. That's going to be 3 months. So just explain and say, look, I might see you only, it's based upon what your need is. Like I might see you only, 6 times over the course of 3-4 months. I might see you 12 times over the course of the entire year, because I need you to keep you progressing, at least creating a change of stimulus. Usually if you create the challenge, or if you have a conversation about like, you need to change the exercises once every 6 weeks, then they'll have a little bit more ability to come in and continue care. Now, there are people who discontinue care after symptoms because they're just, symptom junkies. That is how it is. And I would urge you to not do the I told you so when they come back, or if they come back, or I would mention to them, say, look, usually I mention this on day 1 or day 2. I say, look, what I've given you right now is temporary. It's not complete, and it's not a good long-term plan. If you do this forever, you will have pain again in a different way or in the same spot. Please come back and let me complete the progress, complete the program with you. And they're usually very open to that. Okay, now we're on to the last question. So, do you work on quote unquote SI instability, quote unquote? I'm getting a lot of these right now referred from Pilates instructors. I'll be honest with you. We did a workshop on SI joint problems. Let's just say SI joint actual region as being the problem recently. And so I texted a couple other clinicians that I really respect. And I said, can you tell me the history of any SI joint problems that you've really found? And so one guy's like, God, I've been in practice like 6-7 years. I remember seeing this one. Someone else said the same thing. And I've seen one as well. I don't think those are really instabilities. I bet there's something else. And there's other things that refer to the SI joint that I bet if you like, I bet if someone came in with SI joint pain, like within 1 week, we can get them to feel better by doing a single step 2. What you're probably looking at more so is some type of spinal referred. Usually in the posterior aspect of the hip, we're looking at more spinal referred. In the anterior aspect, you're looking at more actual joint, hip, FAI, labral tear, things like that. I think very rarely do we actually find muscle pain or SI joint pain. But I mean, there might be. It's just it's not as common. Now, don't go anywhere. I'm going to save myself some time here. And by the way, you have the opportunity to ask more questions if you like, but I'm going to go over back into the PowerPoint one more time. Because I do get questions later about, hey, what do I do now if I'm actually interested in working with you or looking at these workshops? So I'm just going to answer those questions now. Okay, here's the schedule. So starting this Saturday, there's going to be, we're going to start with hip, And then this rest of the schedule is roughly every 2 to 3 weeks. Shoulder, lumbar, cervical, and there's going to be a double day on June 13th, which is going to be lumbar, cervical, and radicular. Again, there's going to be a 30-minute break between each one. These are rough times, about 2 hours. I will not leave early, and I might stay late, but if I got nothing else to say, or you got no other questions, and every question's been answered, it might only take an hour and 45. Here's what I want to offer everybody. And I know a lot of these webinars is like, oh, there's a sales pitch at the end. No, really. Okay. If you're interested in what I was talking about, here's what I want to provide to people. And I want to limit this to only 20 docs because I might drive myself crazy to have more. And so I want to have the relationship, basically what I had with interns that come into the office, and they're dedicated to be there. All right. Jeremy has worked with me. Kyle has worked with me, Nathan, Don, Sarah. They can all text me an email whenever they want and ask about, hey, I'm having the problem with this case, and hey, I need to figure out a step 2. What do you think about this? I'll be like, why don't you try that? And they'll say, oh, that's a good idea. I'll try that. And they try that, and it might or might not work, but it's a learning process. And so you'll get access to me. And so someone asked me before, like, well, why can't I have access to you if I just come to one workshop? Well, because do you ever get access to McGill if you just come to one McGill workshop? No, like that's it. So I want you to have access to me for a period of time to help implement into your practice. Again, I'm not trying to change your practice. I'm trying to help improve everybody, level everybody up. And so if you only do one workshop, which I strongly want to discourage, you will not more than likely use this any aspect in your practice because it'll be too hard to implement because you have a normal based business patient workflow. But I want you to be able to tinker reasonably. And so it'll be access to me either via webinar or text or emails or so on. I want to make sure that we answer everybody's questions in the best format that we can. And webinar is easiest because that way everybody has the same, like they have a good learning experience. Also too, and someone else mentioned this that signed up for it, is they said, I really like that I can talk to other people that have like-minded, they're like-minded. And I said, that's a good point, because I feel like I can text Philip Snell, Ben Ramos, Cody DMAC, and my interns at any point about these problems, and they practice very similarly. So they're going to have very good input versus someone else that maybe practices around the corner who doesn't have the same biases and the same skill sets. So I want you guys to develop those relationships, and you can also brainstorm with these people, whether I'm there or not. Like, each other, go talk to each other. And so there's one-time payment with that. Docs obviously pay more than students. I know students' money's tight, but reach out to the workshops that are gonna cancel. If they haven't already, you're probably gonna make $500 back. So I'd strongly urge you put it to here. If I was a student in your situation and I wonder, what should I do to best improve my ability to learn how to clinical reasoning as well as treat people? I'm gonna refer you to other spokes, but at the same time, okay, I mean that in the most honest way possible, because this is what I wish I had. If you're doing a la carte, you can certainly do one at a time. I'm going to make it available on my website after recording, but there's not going to be, like, if you text or email me or something, I'll answer, but it's not going to be a long process. I hope you understand that, because I can't do that with everybody. And so if you want part of it, I have Venmo or PayPal options. So that's these, or just email me back and just ask what they are in case you forget. I'm going to go back to the Q&A at this point. See if you guys have any last questions before we stop and everyone enjoys their holiday. Okay, no more questions. Great. Thanks everybody for coming on. This was fun. This is the last time I intend on doing this certain 5-step webinar. This will be available for recording if you have friends who you think might want to listen to it. But other than that, this is not like an ongoing thing. This is not going to be like a part of the business. The only reason I did this in the beginning was because there's so many docs trying to jump onto our workshops that are Gen Pop based, like SI joint and lumbar spine, and like anything you see us post on Instagram that is a condition based thing. Those are for patients. We're trying to build patients too, and so those are not going to be interesting information for you anyways. So this is the place, this is the time to be able to learn as a clinician while you guys are stuck at home. So thanks everybody for coming, and looking forward to working with you and helping you through everything. See ya.